two beautiful countries in the world, India and Australia. This is eCritCare Podcast about evidence-based critical care medicine, helping you to save lives. Here are thoughts on controversies in critical care. And now, here are your hosts, Dr. Swapnil Pawar from Sydney and Dr. Jose Checco from India.
Welcome to eCritCare Podcast. This is our episode number 107. And today I'm joined by my co-host, Dr. Jose Checco. Welcome, Dr. Checco.
Hi, Swapnil. Good evening. How are you?
I'm good, thank you. Today we are going to discuss another important landmark trial which was recently published in New England Journal of Medicine. And this trial is important from many aspects. I guess, obviously, this trial adds a significant body of evidence into sepsis resuscitation literature, but also it has definitely challenged the ongoing consensus amongst the critical care specialty about the fluid resuscitation strategy. So the name of the trial is CLOVERS Trial. And we have discussed another randomized controlled trial, which was published on a similar topic called as Classic Trial. So CLOVERS Trial is in many regards similar to Classic Trial, but has obviously got key differences. I think that's why it's important to discuss this trial in depth. So just to add a bit of context to this trial, intravenous fluid resuscitation has remained a cornerstone of treatment in management of patients with septic shock and sepsis-induced hypotension. And we all are familiar with the very well-known REVERSE trial, which was published back in 2001, which suggested that protocolized management of resuscitation in patients with septic shock will lead to improved mortality. And obviously, REVERSE trial was criticized because of it was a single-center trial. It was based on one particular protocol, and it was not a very well-conducted randomized controlled trial. Subsequently, we had many randomized controlled trial discussing how to resuscitate patients with septic shock. Over the period of time, what we have learned from the sepsis literature is less is more. And that debate has triggered following surviving sepsis guidelines, which has almost 4 iterations so far, which almost kind of advocated for this fixed dogmatic approach of fluid resuscitation with 20 to 30 mils per kilogram volume resuscitation at the beginning. And over the period of time, we have swayed towards using the restrictive fluid practices because we all agreed that intravenous fluids are also drugs and they do have side effects, which we have seen with starch and other colloids, and even with some of the crystalloids such as 0.9% saline solutions where we get hyperchloremic acidosis. We tend to see more side effects once patient receives 4 or 5 liters of fluid after the initial presentation. So over the period of time, the practice has changed, evolved, and we swayed towards early use of vasopressors in this subset of patients. And restrictive fluid practice has become more prevalent in many parts of the world. However, the vasopressor therapy also has got its own risk because in many centers, if we have to administer noradrenaline as a vasopressor of choice, the patient will need a central line, and that has got its own side effects. Also, vasopressors has a significant other risk factors such as tissue ischemia, increased cardiac workload, and arrhythmias. So I guess this debate has been ongoing around how much fluid resuscitation should we practice in the initial resuscitation timeline when patient is admitted to emergency department. So this liberal versus restrictive fluid strategy has remained still unanswered. Now, Classic Trial did not show any difference in the mortality with regards to restrictive or liberal fluid resuscitation strategy. CLOVERS Trial, which stands for the crystalloid liberal or vasopressors early resuscitation in sepsis, it was designed to compare the effects of restrictive fluid strategy with early use of vasopressors to a liberal fluid strategy. And the hypothesis which was proposed in this trial was a restrictive fluid strategy used during the first 24 hours of resuscitation for sepsis-induced hypotension would lead to lower mortality before discharge home by day 90 than a liberal fluid strategy. So, Dr. Checco, can you please walk us through the methodology and limitations of this trial, please?
Yes, indeed, as you suggested, Swapnil, it's a very important question in sepsis as to how much fluid resuscitation is good for your patient. So this CLOVERS study sought to find answers to this burning question that's been going on for a very long time. How did they do it? The study was conducted between March 7, 2018 to January 31, 2022. And it was a multi-centric trial involving 60 centers in the US and included 1,563 patients. Adult patients with suspected or confirmed infection and hypotension with a systolic blood pressure of less than 100 millimeters of mercury after more than 1 liter of IV fluids were considered to be eligible for the study. They excluded patients who were more than 4 hours after meeting the eligibility criteria that I mentioned, more than 24 hours after presentation to hospital. Patients who received more than 3 liters to begin with were excluded. Patients with obvious signs of fluid overload were not included. And the opposite situation wherein severe hypovolemia, not presumed to be due to sepsis, if that was the problem, such patients were also excluded from the trial. Randomization was in a 1-to-1 ratio to a restrictive or a liberal fluid strategy, which I will describe later on. They calculated a sample size of 2,320 patients to begin with to demonstrate a difference of 4.5% in the primary outcome, which was death before discharge, in favor of the restrictive group. So 15% in the control group versus 10.5%. So this number would give the study 90% power and a two-sided alpha level of 0.05. So how did they protocolize the restrictive and the liberal fluid strategies? In the restrictive group, bolus fluid of up to 2 liters was allowed in the pre-randomization stage. And once they reached this limit of up to 2 to 3 liters, they would start norepinephrine and a second vasopressor if required to maintain the mean arterial pressure more than 65 millimeters of mercury and a systolic blood pressure of more than 90 millimeters of mercury. So bolus fluid of up to 2 liters allowed pre-randomization. Then you switch to vasopressors, norepinephrine to begin with. Second vasopressor if required, if the blood pressure remained less than 65 mean arterial pressure or a systolic pressure less than 90. And in the restrictive group, you could give what they call rescue fluid, which is bolus fluid, in case of severe hypotension, meaning a systolic blood pressure of less than 70, mean arterial pressure of less than 50. So that was severe hypotension. Or if they had refractory hypotension, which is systolic less than 90 and MAP less than 65, with the norepinephrine going up more than 20 micrograms per minute, heart rate of more than 130 per minute, lactate more than 4 millimoles per liter and rising, extreme hypovolemia, they had criteria for this, as well as on the clinician's judgment, if they deemed that more fluid was required. So if any of these criteria were met, you could bolus them with 500 mils of fluid, which is termed as rescue fluid. So that was a strategy or protocol in the restrictive group. What did they do in the liberal strategy group? 2 liters of fluid was allowed at randomization. Later on, they amended the study saying that you could restrict to 1 liter if that was enough. And they gave additional boluses of 500 mils if, similar criteria to previously, systolic blood pressure was less than 90, mean arterial pressure less than 65, lactate levels of 4 and rising, urine output less than 30 mils per hour, tachycardia more than 110 per minute, use of vasopressors or based on clinical or measured assessment. So they could keep on giving 500 mils of boluses in the liberal group. And here again, there was the option to use vasopressors in the rescue mode if severe hypotension persisted, meaning a systolic blood pressure of less than 70, mean arterial pressure of less than 50, lactate 4 or more and rising, fluid overload state wherein you couldn't give any more boluses. More than 5 liters of fluid had been already given. And also, if the clinician judged as that the situation deemed vasopressor use, they could use vasopressors as well. So in both the groups, there was the option to deviate from the protocol based on clinician judgment. In the restrictive group, they could use bolus fluids based on clinician judgment. And in the liberal group, they could use vasopressors as well, again, based on clinician judgment. What were the findings of the study? The study did not continue for the sample size that they had projected of 2,320 patients. It was stopped for futility after the second interim assessment after enrollment of 1,563 patients, which is short of the sample size that they had calculated to begin with. The patients were well matched at baseline. And if you look at the volume of fluid infused between the restrictive and the liberal groups, there was a distinct difference. In the first 6 hours, it was 500 mils versus 2,300 mils, restrictive versus liberal. 24 hours post-randomization, it was 1,267 versus 3,400, nearly twice as much. So there was a distinct difference in the volume of fluid administered between the restrictive and the liberal arms at 6 hours and 24 hours, and inclusive of the pre-enrollment fluid. There was a wide, well-differentiated difference between the restrictive and the liberal groups. Vasopressors were used in 59% of the restrictive arm, 37% in the liberal arm. Ringer's lactate was the most common fluid used. And they also found that in 500 patients, they administered vasopressors through a peripheral intravenous route, not through a central line. And they found that by and large, this was completely safe. There were only 3 possible instances of extravasation out of these 500 patients. And none of these patients had any adverse clinical consequences at all from the presumed extravasation. So much for the initial data. Now let's look at the outcomes. The primary outcome, as I mentioned, was death before discharge at 90 days. This was 14% in the restrictive arm, 14.9% in the liberal arm. The difference, of course, was not statistically significant. They looked at several meaningful secondary outcomes as well. However, none of these secondary outcomes differed between the restrictive versus the liberal strategy groups. The outcomes that they looked at as secondary outcomes included organ support-free days at 28 days, no difference. Ventilator-free days at 28 days. Renal replacement therapy-free days at 28 days. Vasopressor-free days at 28 days. ICU-free at 28 days. Hospital-free at 28 days. None of these differed between the restrictive versus the liberal strategy group. They also looked at all-cause mortality at 90 days, regardless of the location of the patient at that point of time. Again, the results were similar. 22.4% mortality in the restrictive arm at 90 days, all-cause mortality, versus 21.9% in the liberal arm. Here again, no statistically significant difference. So essentially, this study found that although there was a distinct difference between the volume of fluid administered in the restrictive versus the liberal arms, there was no difference in mortality at 90 days before discharge. There was no difference in the all-cause mortality at 90 days, nor the level of organ dysfunction, ventilator-free days, ICU-free days, and hospital-free days. So that's the gist of the study, which really did not find any difference in meaningful clinical outcomes between a restrictive and a liberal fluid strategy in patients with sepsis.
Thanks, Dr. Chak. It's a very interesting and important trial. The key things to look at is some of the baseline characteristics of the patients enrolled in this trial. So with regards to age, on an average, it was like around 60 years of age in both subgroups. Female-male distribution was almost equal. And race-wise, obviously, it was conducted in predominantly white Caucasian population. And that might be a slight limitation with regards to external validity, as whether different ethnicity will have a different response to these different strategies. And that's something we probably won't be able to answer based on this trial result. I guess the trial was really well conducted. And one of the key difference between this trial and a classic trial, that the patients enrolled in this trial, all patients came via emergency department. There was no patient who came from theaters or ward where they had already had fluid resuscitation, which was not accounted for. So I guess the key thing about this trial is that the patients presented with septic shock to emergency department and got enrolled straight away in emergency department before coming to ICU. In terms of the median volume of IV fluid administered, the trialist really managed to kind of separate these two groups very well, where in first 6 hours, restrictive fluid group strategy received only 500 versus liberal fluid group received almost 2.3 liters of fluid. However, the vasopressor administration within the first 24 hours was only 59% in restrictive fluid group versus 37.2% in liberal fluid group. So what does that tell us is probably still 40% of the patients, even without getting large volume of fluid, get away without receiving any vasopressor therapy. It's just a common sense approach to give fluid, monitor, and most of the patients might not need vasopressor therapy at all, which is also quite important finding. And also the duration of vasopressor therapy in terms of first 24 hours was not more than 10 hours in the restrictive fluid group, while in the liberal fluid group, it was only 5.4 hours. So even patients require vasopressors that don't last for longer period of time. In terms of the mortality, it was very important to note that in both groups, the mortality was only around 14 to 15%. And what does that show is over the period of time, our resuscitation practices has gotten better. And even when you look at ARISE trial, PROMISE trial, or PROCESS trial, the mortality was around at 18 to 20%, while this trial clearly showed the mortality in septic shock patients who require fluid resuscitation and or vasopressor therapy, the mortality is only 14 to 15%. So probably over the period of time, our resuscitation practices or understanding of the pathophysiology of sepsis has gotten so much better that the mortality has gone down from almost close to 70% in REVERSE trial, now down to 14% in CLOVERS trial. So there are a lot of positive things about this trial that we need to consider. In terms of the limitations of the trial, I guess this trial was unblinded trial, and I think that something will automatically add bias to interpretation of the results. Although the trial was protocolized as to when to initiate vasopressor therapy or not, and the fluid resuscitation was not really protocolized, and it was not guided by various methods of volume assessment. And obviously, it was left to the clinicians to decide how they want to guide their initiation of vasopressor timing. So there was no use of non-invasive hemodynamic devices or sonographic assessment criteria or use of bedside echocardiography to assess the fluid responsiveness or volume status suggested in this trial. And this trial compared either a vasopressor predominant strategy of resuscitation or fluid predominant approach towards the septic shock resuscitation. And this trial put all the patients with septic shock in one basket, but did not look into some of the subgroups of patients with different diagnosis or different coexisting conditions who might have responded differently to either of those strategies. So the trial was clearly not powered to look at those different subgroups. And they enrolled the patients very early when they presented to emergency department. So again, those findings cannot be generalized to patients who present late into their septic shock trajectory, and how to guide the resuscitation in those kind of subgroup of patients. Again, it's a bit uncertain based on these trial results. And another key limitation of this trial is the targets that they used for resuscitation. And again, as I said, they compared predominantly two strategies, the vasopressor predominant versus fluid predominant strategy. They didn't really compare which map targets are useful, because if you obviously target different maps, the requirement of vasopressor or fluid would have been quite different. So this trial again doesn't answer that question. However, one of the another key finding for this trial is they gave vasopressors via peripheral access and avoided to put central access, and demonstrated the safety of that approach. So I guess it's safe to say that in future, this strategy is something can be considered, that giving the vasopressors via peripheral route for a short period of time, it may not be unreasonable based on these trial results. So there are various pluses along with some major limitations of this trial. So Dr. Chacko, how do you look at this trial, and how do you see the practices changing in your center based on this trial?
Yeah, it is a very relevant question to ask as to whether you should use a conservative fluid strategy or a liberal fluid strategy in patient septic shock. A question that has been asked several times over the years with no definitive answers. And this trial was a very timely trial and very well conducted. Unfortunately, we don't have any answers, any direct answers from this trial, because there was no real difference in the outcomes, the clinical outcomes between the restrictive and the liberal strategy. There are several reasons as to why they could not identify a difference. One of the points that I consider may be important and something which may be tried out in future clinical trials as well. Although there was a difference in the volume administered between the two groups, that was, of course, quite a distinctive difference. However, even in the restrictive group, the patients had already received up to 3 liters of fluid prior to enrollment to the study. So you may argue that itself may be a large enough volume, which could perhaps be considered to be a liberal approach. And in fact, there have been criticisms leveled against the initial bolus fluid of 20 mils per kilogram that was being proposed by the surviving sepsis guidelines as well. So that's one of those things that you need to consider. How much fluid should you give initially? Should you really use the target of 1 to 2 or 1 to 3 liters as was used in this study? The second important question is, there was, of course, deviations from the protocol based on the clinician judgment, which is like a real life study wherein you cannot stick rigidly to a protocolized situation. You may have to vary. That is acceptable under most conditions. The study was limited to 24 hours. So the question arises, if you continue the strategies for a longer period of time, would that make a difference? And as you rightly pointed out, these patients were very early in the sepsis phase, and they were caught very early as they presented to the emergency department, and appropriate treatment was initiated relatively early, which is in contrast to the situation in many parts of the world, particularly in our own setting, where we very often see patients quite late in their illness. And the question arises, would these results really apply to patients who are later in the phase of sepsis and septic shock? And when this study was actually commenced, there were several criticisms against it by various citizens groups who contended the trial was just comparing two entirely experimental arms, and there was no control group, which they found it hard to stomach. But of course, both the groups had the obvious criterion to go by clinician judgment, if at all they wanted to deviate from the protocol. So that way, it was approved. And today we have a study which compared these two strategies. But as they did not come up with any positive finding, I'm not sure if it's going to change our practice very much.
Yeah, that's correct. As you mentioned, even the restrictive group was probably not exactly the restrictive group. So it still doesn't tell us that answer. What if the patient has received only 500 mils of fluid compared to all the other amount of fluid that they received before getting enrolled into the study? Key point in resuscitation of these patients that you really need to stand at the bedside and see the responsiveness to amount of fluid that you are giving to the patient. And if they're clearly responding to initial fluid resuscitation, yes, you continue with the fluid resuscitation, but you tend to stop early if they really show signs of all the harms secondary to fluid resuscitation. So I guess it's very important to have that vigilant approach, and rather than going through this dogmatic strategy of liberal versus restrictive, because even those definition of restrictive versus liberal are a bit blurred for me. I guess whether you will call 1.5 liters of fluid either liberal or restrictive, it's kind of debatable, I guess. So up to 2 to 2.5 liters of fluid resuscitation for me in my practice is reasonable. Having said that, if they are needing more than 2 to 2.5 liters fluid, commencing the vasopressor therapy is pretty reasonable approach for me. But I think instituting monitoring devices, looking at the trajectory of the patient and using the multimodal approach to resuscitation is probably the key, rather than kind of sticking to one fixed approach. So you're right. This probably won't change my practices, but this trial definitely adds a significant body of evidence to the current literature. So thanks, Dr. Chakor. Thanks for your time. We'll be back in fortnight's time with another critical care related controversy. So till then, goodbye and have a nice time.
Thanks a lot, Sapnil. Thanks everyone for listening in. We'll meet again in a fortnight's time.
Thanks for listening to eCritCare Podcast. If you like what you just heard, we hope you'll pass along our web address, www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Be sure to check out our archive section on our website for previous podcasts. Check us out on Facebook at Critical Care Education. Join us next time for another edition of eCritCare Podcast.